welcome to the HPL seminar. We have a short, small gathering today, but I'm glad that everyone joined us when I called you out at your offices. So thank you for doing that. It is my pleasure today to welcome you to our speaker, who is Dr. Khurelbaatar, who is a postdoctoral associate in the Edwards Lab here at the Human Performance Lab at University of Calgary. You all know him better as Tsom, and so I'm going to refer to him as Tsom as well moving forward in this introduction. So Tsom holds a Bachelor and Master of Engineering in Mechanical Engineering from the Mongolian University of Science and Technology, which he completed in 2008 and 2016 respectively. He also completed a Master of Science in Biomedical Engineering in 2019 from the Worcester Polytechnic Institute in the US under the supervision of Dr. Karen Foy. As part of his thesis, he used quantitative imaging and computational modeling to explore how mechanical strain influences changes in the distal tibia during marathon running. Most recently, he earned his PhD degree in the mechanical engineering from the University of Alberta in 2024 with a dissertation focused on the mechanical environment and morphological adaptations of cranial sutures during normal growth. In his PhD, he was supervised by Dr. Dan Dominic. A fun fact about Tsom is that he's lived, studied, and worked in 4 different countries, moving across borders with his family 5 times and even crossing oceans 3 times along the way. His talk today is titled Mechanical Environment and Morphological Adaptations of Cranial Sutures During Normal Growth. Thank you, Tsom.
Thank you for the introduction. Hello. So before delving into my talk, I have a quick question. Do you guys know how many bones are there in human skull? Not including teeth. Any guess? 4, 5? Yeah, I thought similarly. Before starting this project, I thought maybe there is jaw and the rest of the skull, maybe 2. But it turned out there's 22 bones in human skull. And all those separate bones are interconnected to fibrous joint called sutures. So today I'm going to talk about this suture. So it mostly consists of collagen, proteoglycans, various cells, musculature, and nerve fibers, and obviously water. And in terms of morphometry, it can be straight, butt-ended, just like this medium palatine suture, or tortuous, interdigitated, like this vegetal suture. The interdigitated or interdigitation term is just like referring to the shape when we interlock our fingers. So from now on, when I say interdigitation, it's just talking about the tortuosity of the suture. And in terms of mechanical environment, sutures work under quasi-static loading caused by intracranial pressure and cyclic loading caused by mastication, blood pulsation, locomotion, and impact loading caused by falls, accidents, fighting, etc. Besides joining the skull bones, sutures also act as a shock absorbers and dissipate energy and transfer load. In terms of biological functions, suture is one of the 2 main function or mechanisms of bone growth in the skull. It turns out there's no growth plates in our skull. In skull, there's a thin bone, and it grows with coordinated absorption and deposition of the bone minerals inner side of the suture and outer side of the suture, outer side of the skull. With that mechanism, sutures can, skulls can expand outward, but to fill the gap between there's bones growing at this suture bone interface. And another biological function is this suture adapts to the loading condition. When there is a compression applied quasi-statically, there's a less bone growth, but same compression applied cyclically, there's an increased bone growth, and increase interdigitation. When applied, because I said the tension creates also bond growth, but the new bond tend to be thin. But cyclic tension reduces interdigitation but increases bond growth. So obviously now we understand, even though we don't really know, it's not visible out from the outside, but this structure is very important. So what will happen? Something, some abnormality occur to the suture, so it can cause various different disorders, and if left untreated, it can lead to abnormal head and face shape, airway obstruction, vision and hearing impairment, intellectual impairment, and even delayed development. Okay, so let's shift gears a bit. So in order to measure morphometry of the suture, we can use many different things, including length, or width, or thickness. But in this study, I focused on the two main things. First one is the linear interdigitation index, and it represents how tortuous or complex the suture structure is. And it's defined as a ratio between suture length along its core path to the linear distance between suture ends. Next one is the suture width, and the shortest distance between opposing suture bone interfaces. Okay, and also we can measure or estimate mechanical state at or around the cranial sutures. There's many studies measured strain at the suture with strain gauge. So, for example, in this study, they used strain gauges to measure strains along several different sutures during mastication. And with that, they were also using double fluorochrome labels to estimate the bone growth at the suture bone junction. But downside of the direct measurement is strain gauge such as giving false strain across the suture at the selected few points, not real strain distribution. And then other researchers using computational models developed did research and estimated strain distribution along the suture and the bones surrounding them. So as I said earlier, in this direct measurement, they were measured strain during mastication. But there is, as I earlier mentioned, there is another type of clotting condition, which is quasi-static clotting caused by intracranial pressure. And there's almost no study looked into that. There's only a couple of studies used pinweld pressure vessel analysis to estimate strain caused by intracranial pressure. Why intracranial pressure is important is because during the early development, when the skull is actively, when the brain is actively growing, it causes high intracranial pressure, and to accommodate that rapid growth, skull also grows very quickly. So intracranial pressure is one of the main driving force of the bone growth at the intracranial cranial suture bone junction during the early development. But there is a quantitative mechanobiological link has still not been established. So the goal in this project was somehow contribute to filling that void by investigating the mechanobiological relationship between morphometric measurements, bone mineralization, and biological adaptation with respect to the localized mechanical strain. I aim to achieve these goals through following three objectives. The first one was obviously perform morphometric measurements and evaluate bone mineralization along the suture bone interface. Second one was to develop MI of the management modeling approach and estimate suture strengths and how it's changing over time. Finally, to combine outcomes of these two objectives and establish mechanobiological relationship. Okay, here's my first study towards objective one. In this study, I did animal experiment with 12 fragile rats and performed in vivo micro-CT scans at various time points. And the bone group was dynamically traced with strontium granulate. So strontium granulate is strontium is the alkaline earth metal similar to calcium. When administered to body, it substitutes about up to 5% of the calcium in the hydroxyapatite compound. Then that will be deposited to the bone matrix. And it will stay there unless it's resolved. So it's very stable. Then after the administration and preparing the sample, we can detect the presence of the strontium, which tells us where is the newly mineralized bone. We can detect that with KH subtraction based on the synchrotron X-ray. Advantage of that will be 3D map of the new bone mineralization. But I wasn't able to do that. Instead, I used electron microprobe to estimate or find the presence of the strontium. Okay, so here's the overall workflow. First, I started with micro-CT image. Then it was segmented. Bones were segmented around the coronal suture, which was the suture of interest for me. And then endocranial after surface and extracranial inner surface of the skull was extracted. And then surface function was fitted to that. Using that surface function, I was able to reslice the initial micro-CT image. And with more image processing, I was able to get binary image of the coronal suture. Finally, using marking algorithm, I measured morphometry of the coronal sutures. Okay, why curvature slicing? Have you ever heard anything like curvature slicing? So there's few methods similar to this, but I haven't really found anything exactly the same as this. So the reason to delve to this complex method was if I have this cross-sectional image, and if I want to see the sutures, I need to select a plane across the suture of interest and do the resizing. It will give me standard slide, but the downside, it cannot represent the entire suture length because suture is located along the curved skull, and also it doesn't maintain the relative deepness, relative location through the skull thickness. Because not only sutures have complex structure along its length, it also shows that complex structure as it goes through the thickness of the skull. So instead of flat surface, if I get curved surface along the curvature of the skull and get the reslicing down along that surface, I will get this image. And then if I somehow unwrap it, make a 2D image, now I can use this image with my marching algorithm. And now it can cover the entire length of the suture, and it maintains the relative location through the skull thickness. So I created 11 curved slices between outer and inner surface of the skull, and basically it covered inner 90% of the skull thickness. Then I was able to perform morphometric measurements using this marching algorithm. So again, based on the camera image, I can detect top and bottom curves or top and bottom suture bone interfaces. And also I can detect medial axis of the suture using segmentation process. And the width was measured as a shortest distance between top and bottom group to each point of the metaverse. Then finger interpretation index was calculated as a ratio of MA meta-axis to the linear distance. But as you can see here, there is some problematic area because I'm trying to find the shortest distance between two different top and bottom interfaces. Because of that, it's skipping over some of the important parts where the suture weight is the highest. So in those areas, I performed intermediate addition measurements. Here's my statistical tests and statistical model. So for the statistical model, I've used linear mixed effect model. And age and visiting the question through the skull was the input, and also initial measurement that the inner surface was considered as a random factor. Okay, here's the result. So from here, first thing you can see is there's a clear trend from 10 weeks of age to 16 weeks of age. LII is increasing. In other words, suture complexity is increasing, but suture width is decreasing. So as rats age, suture is getting more complex, but it's getting narrower. And it was all significantly different between different ages, except between 7 to 9 weeks of age. So as for the mixed effects model, we were able to explain 97% and 86% of the variance in suture LII and width. So basically with this predictive model, we're able to tell how the suture will change based on the initial suture measurement. In summary, we developed this novel approach and quantified morphometry of the rat coronal suture and created a predictive model. With this study, half of the objective one was fulfilled. Okay, it's my second study towards second objective. So here I developed anatomy model and estimated the strengths along the suture and how it's evolving with age. Okay, first thing, I know there's, I don't know, maybe I hope there's many of you guys do anatomy modeling and familiar with this. But the first thing for the anatomy model is the preparation of the geometry or the segmentation of the CT image. In this specific case, my geometry was this one. As you can see, it's very complex and it was very difficult to just segment based on the thresholding or few clicks of the button. So instead of making time-consuming manual segmentation, I tried to put together a few built-in functions of the mimics to make semi-automatic segmentation. So first, minimum threshold was determined based on the histogram of soft tissue and bone, and then initial bone mass was created, and then it was separated into different bones using split mass operation. Then after a few cleanup and other smart field operations, we were able to get this final bone geometry. And then filling the gap between the bones, I was able to get the geometry of the coronal suture. Okay, next, I tried to create two-stage anatomy model. So the reason for that is I'm trying to apply intracranial pressure routing. In order to apply intracranial pressure, I need to have whole skull. But if I want to make the whole skull, the geometry will be way too complex to segment, and resultant model will be way too big and will cost demanding in terms of computational cost. So I simplified the model with the half of the cranial vault and all the suture network. But in this time, I didn't really segment the sutures. I just placed the suture at the outer surface of the skull and extruded it through the skull. But at the coronal suture, I was able to create small detailed model with all the intricate details of the suture and the surrounding bones. Then based on the simplified model, I can get the cut boundary constraint, namely the statement, then apply that as an input in the detailed coronal suture model. Then I want to get the points of interest along the suture bone interface. So I selected those points at the ectocranial, endocranial, and three planes between them. And those points were selected based on the convex, concave, and straight. For example, this is the convex region of the suture, and this is concave, and this is the convex, and this is straight region of the suture. Once I define those on the 7 weeks of age scan or model, I tracked them across different time points based on the same features. And finally, I selected volumes of interest, which is 30 by 30 by 30 micron cube, centered at the points of interest, and all the values were averaged across all selected nodes within that volume. Okay, I use mostly non-parametric tests because the distribution of the data was not normal. Okay, here's the representative image. On the left, you can see how the suture and the strength distribution is when the animal was 7 weeks age. On the right, you can see how it's in 16 weeks of age. First thing, again, suture is getting more complex but narrow. Together with that, strain is also increasing. So when we see all the points together, there's trend increasing. The magnitudes were increasing with age up to 11 weeks of age. Then it was decreasing up until 16 weeks. But if we look all the different regions separately, concave region had high magnitude of strain regardless of the minimum or maximum principal strain, which also coincided with the high bone growth. And with this, I was able to make final segment models and estimate strains and how it's changing over time. And basically, the strain amount was age dependent. As age increases, it was changing, and also it was region specific because in different regions it was showing different behavior. With this, my objective 2 was my last study. So here you can see my rat recording sample. From this sample, I'm carrying out the region of interest, which was derived with the coronal suture, and it was embedded in epoxy and polished to expose the cross section that I want. Then with the Tsom microprobe, I was able to detect percent of the strontium. On this image, all these bright orange areas are showing the strontium percent, which is newly mineralized bone. Then the strontium distribution image, I was able to again detect the top bottom interfaces and selected the points of interest along the switching point interface. Again, I tried to use create similar or equal amount of points in the concave, convex, and straight regions. And then I filtered out all the pixels except with the strontium percent, then created normals at the sutures of points of interest, and finally measured the width of the strontium band. So it will give me how much bond grew within the duration of the strontium administration. With that, I was able to calculate mineral oxidation rate. Okay, so now I got finite element modeling base frame and strontium deposition base on mineralization. If I put them together, I can get relationship, mechanobiological relationship between biological adaptation and strain. But before that, I needed to figure out one more thing, which is on one side, I have 3D geometry coming from CT image, but on the other side, I have 2D image coming from electron microprobe analysis. So in order to compare them together, I need to somehow specially put them together and find the exact same cross section from this 3D geometry as this 2D image. So I was able to find that using machine learning based algorithm. In this case, I've used genetic algorithm. So basically, I was able to find among these CT images, find the exact same cross section of the geometry. So on this image, pink parts are showing the strontium deposition map, and green parts are showing the bone coming from the CT image. And when they perfectly overlap, it will turn into white. So here's the parameters of the genetic algorithm. And basically, it was minimization program to minimize between square difference between the pixel intensities of the two different images. So it consists of two different loops. In the outer loop, using genetic algorithm, it's minimizing the error while we are changing X, Y rotation and Z translation. And in the inner loop, it's minimizing the error, changing X, Y translation and Z rotation. Okay, now I put everything together so I can do a statistical analysis and find mechanobiological relationship. So here my hypothesis was high energy equivalent strains and strain gradients will lead to higher amount of adaptation. Okay, here's the results. First thing, the mineral adaptation rate was varying between 0.25 to 8 microns per day. The bonds were growing that much amount. And on the other hand, the strain energy equivalent strain was varying between 8.7 microstrain to almost 4,000. So there was big variation. And then if we look all data points together, students were able to explain about 33% of the variance in the mineral deposition rate. The main predictor was energy equivalent strain gradient at 16 weeks of age. But if we separate the concave region, which is the most bond growing parts, so in that region, energy equivalent strain gradient at 16 weeks was alone able to explain about 53% of the variance in mineral deposition rate. So in summary, this study was the first study that combined strontium-based mineral deposition rate and modeling to quantify the mechanobiological relationship in cranial sutures caused by intracranial pressure. And we were able to establish mechanobiological relationship. And it showed that intracranial pressure caused strain gradient was the main predictor of the mineral adaptation rate. And also there was some statistically significant effect from the strain gradients at the usual time point, but the size of the effect was very small. With this, I was able to accomplish all my objectives. And here's my references. Thank you. So, it's slightly different from what you do normally, but I hope there will be a lot more questions for me.
What's the benefit of these sutures so that the edge they get narrower,
Mhm.
they get complicated?
So the first benefit will be, yeah, not maybe first, but one of the main benefits will be when child hurt, all these sutures, because of all these sutures are there, the bones could overlap and skull can get smaller, so babies can born. So that's the main thing. And then again, this cranial suture bone interface is the one of two main bone growth sites in the skull. If there is no suture, there won't be no bone growth. For example, there is a disorder, cranial synostosis, which is premature occlusion of the sutures. And at that part, there won't be any more bone growth, but the brain will be still growing in young babies. So in order to compensate that growing size of the brain, other side of the skull will grow, and that causes that weird head shape. Maybe I can show you on the image. First introduction part. I'm talking about this one here. So here, there's supposed to be lambdoid suture going around here, but this part of the lambdoid suture is occluded prematurely. And because of that, other side of the bone will be growing and it will cause this weird shape. And as we grow older, there will be much more load. And there's many different, not many, but few theories that sutures are changing the complexity in order to accommodate that increasing load. For example, when we were in the womb, we won't be chewing anything. After birth, we also won't be chewing anything, but after a few months, we will start chewing and there will be much more loading coming from the mastication. And to accommodate that, it's increasing the toxicity, so it makes more resistant. And as we grow older, we don't really need to grow our skull anymore. At that time, all the sutures will be fused together, are occluded, and the bones will be fused together. So that's shown with the increasing age of the rats, the suture will get narrow.
And is there any reason that you look at the maximum principle of strength?
So we can look at various different things, but maximum principal strength mostly associated with the tension, while minimum principal stress is associated with the compression, but in some cases, it can be above compression level. So, yeah, I just wanted to see, is it in tension or is it in compression? Because in previous studies, it is saying with tension, it behaves one way, but with compression, it behaves differently.
Robin and then Adam.
I have a couple of questions about how you modify like the linear distance or like the complexity of four sutures. What is the main factor to the complexity? Is that like the big curve, like kind of a low frequency change, or like all the small changes? Which one would have more importance at value?
Yeah, there's different approaches like fractal analysis to consider the complexity, wavelength, and high frequency of the interpretation. But in most simplest way is linear interpretation index. It doesn't really consider how many interpretations are there or how big of an amplitude do they have, but it's just getting the ratio between path length to linear distance between the ends, and it's quite standard way to define the complexity of the sutures. And I wasn't really looking how to define the different complexity measurements. I just wanted to see how the strain is affecting the mechanobiological relationship. So I just selected this one.
And maybe just another question. So with age, you were saying they were getting thinner and more complex.
Yes.
Is that kind of an optimization mechanism to like limit the strain or having better force transmission or things like that?
Yes. So I believe that is happening, but it's not really proven conclusively. One thing to mention is this suture is connective tissue reaching collision. So there is a fiber orientation. In newborn babies, it's randomly oriented, but as we age and there's a additional loading applied, that orientation changes depending on the loading. So it's clearly adapting to the loading condition. But in my case, I didn't really look into the fiber orientation. We wanted to see the overall shape difference and how it's changing and how it's affecting the strain, or other ways, strain, how the strain is changing driving the changes in the bone. Yeah. My previous lab mate is looking into that right now. Yeah. Thank you.
Thanks for the talk, Tomo. I was wondering, your method seems to have a great approach to figure out normal sort of levels of strain, like how that changes over time. Is the idea with the abnormalities that you identify or bring up on the bottom of this slide here, that like during development, as in you, babies are developing, like, can you identify when something's not going well? And is there some intervention that exists to like correct this? Is it like, I look at the adaptation in the top right corner, like, is it a squeeze? You have to squeeze the baby's head in a certain way to like get things to grow properly, or is there like drug interventions? Kind of what can happen there?
So there's a standard or very common method is just surgery. For example, this type of occlusion, there will be surgery and removing the part of the skull around there and putting the helmet. In some cases, there will be surgery together with the implantation of expansion device. Yeah, so most of the standard treatments include some type of application of the force. So it's still trying to create certain mechanical environment to maintain or make the proper growth of the skull. But surgeons are doing that, but there is no clear study what type of mechanical environment will create what type of effect. Did that answer your question?
Since you have the slide up here, maybe you could just explain where you sit relative to this, because I guess this is in a way the hypothesis you started with, right? So where do your results sit? Say in the top right.
Mhm. So these results, they are not really. Let me talk about these ones first, because these ones are based on the experimental study. They applied force, or during the investigation, they measured force, measured strain. Based on that, the researchers got this deduction, but it's not really saying what type of strain or what type of mechanical environment is happening at the suture, because the suture has this complex environment structure. Even on the global level, even if it's compression on the macro scale, because of all these interpretations and optic oriented suture orientation, it could transform into tension. So it's, in my case, it's really difficult to directly put my results among these. The only thing I can say is, based on my results, strain gradient, not the strain itself, is making, or at least it's highly connected to the bone growth.
Okay, well, maybe you can just explain, do you agree with the top right, or are there parts that you agree with or disagree with?
Again, it's hard to say, because, for example, in orthodontics or some other case, when you move the teeth, when you put retainer or Invisalign or something like that, they will apply force and push the teeth one way, and one side will be under tension, one side will be under compression. But in that compression side, there will be bone resorption. On that tension side, there will be bone deposition, so tooth can move. But in this case, it's not that simple. Based on the same compression, if it's applied statically, it reduces bone growth, but if applied cyclically, it increases bone growth. So I believe these results, but again, just giving all our general understanding between the applied load and the result, not really localized strain or stress environment and bone growth.
Okay, so only in bulk does this.
Yeah.
Well, I find this a little bit strange. I mean, I don't really follow this field, but one of the stories is that cartilage undergoes cyclic compression, and then that seems not to beat the bone growth. And I just find some of this a little bit puzzling. So maybe I'm just behind the times, or but if I'm not totally behind the times, it sounds strange that like cyclic compression would lead to bone growth here, and then in cartilage it would be a totally different story, because during development the tissue has to differentiate, decide what to be, presumably largely based on mechanical factors. So it's just strange to me. Or maybe you can give an interpretation of what's going on.
I'm not an expert on cartilage, so, but in my understanding, or in my basic understanding, the main difference between cartilage and cranial suture is the bone growth mechanism itself. In the cartilage, there is a growth plate, and and it will be endochondral bone group. But here in the skull, it's intramembranous. It's completely different bone group type. And also there is no cartilaginous cell in the suture. It has bone cells along the suture bone interface and other bone growth limiting factors at the middle. So when there's drive or when the conditions are fulfilled, bones will be growing from the outside to the middle of the suture, but it approaches to that middle zone where there is bone growth limiting factors, it stops. So yeah, I'm not sure how to clearly distinguish why it's different from cartilage. So
Well, maybe I could just invite Brent or someone else to chime in. Do they agree with the top right, or do they think that it's kind of too bulk to make sense in terms of mechanics, or what?
I certainly think it's a little bit too bulk. That's the right word to say. It's a little bit too easy to say compressive strains to one thing and tensile strains to another thing. It's kind of old school. But this is very specific to these suture adaptations, right?
Yes.
This isn't just,
it's only for future adaptation.
yeah.
It's not talking about bones on other places or cartilage or.
Thanks. So I have two more questions, and we can let other people ask if you like.
I wanna, well,
Okay,
we're talking about strains, I'll keep talking about strains. I think you showed the higher strains on these concave surfaces.
Yes,
And do you know why? Is it just because it's the way you're loading it and it's a stress concentration feature? So it's just sort of amplifying the nominal strain. That's sort of, you're loading these things in this sort of tensile mode of like normal pressure.
mhm.
So their intention kind of, and then that's a tensile surface of a suture. Is that why it's so much higher than the others?
It's not that straightforward. So here, this middle part will be suture gap, and the concave area of the suture will be around here, which is the protruded intervegetation process of the bone itself. So from this image, we can see there is a higher amount of bone growth, but I can't really tell. How is it causing, there's a more tension or more compression? Again, without looking at the suture fiber orientation, it's again really hard to say. Even though in general it's under compression, it could be in tension. And actually, collagen it works best in tension. So the theory is because of the different loading conditions to optimize to that loading condition, this is creating the more intervegetated complex structure. So in order to achieve that complex structure, bone is growing on this side, but it's getting absorbed from the other side. So it makes that toxicity.
So do you get a lot of marching
Yeah,
through the skull of this thing? So there is quite a bit of resorption taking place.
yeah,
I think. So there's lots of strontium that's being lost
yeah,
through resorption, which kind of limits your ability to really, really look at the relationship between the magnitude of strain and bone formation, because you can't look at on the negative bone
yeah,
formation.
yeah. So that's one reason I think the concave region is more, when we consider the sphincter region alone, it's showing more correlation with the between strain and bone mineralization, because on the other side, maybe we're not seeing anything because there was resorption, but we, as you said, we're not measuring the negative bone formation, so there's some limitation of this study.
The other thing that when I look at that, the junction there, the suture there, it looks a lot like the osteo sort of tendinous junction. Where it kind of, it's very tortuous path that it, and people say it does that to sort of, well, one is maximize surface area. That's maybe something that's happening. The other thing is it kind of shifts the loading environment from, at the interface, from purely tensile to more of shear type of load, which is beneficial at that interface. So, did you ever look at shear instead of max principal strain? I'm sure you probably find the exact same thing. But the other thing I'm trying to understand is like, so I totally understand what the purpose of these things are when you're a kid.
Yeah,
What are the purposes of these things? Like, are they just keeping my skull from popping off out of my head? Like you're keeping, like, what are they doing? Why don't they just become mineralized?
oh, they just become mineralized
Oh, they
when
do?
you grow up, yeah.
Okay,
But certain sutures, for example, different sutures stay very late in the age, but some of them close very early.
okay, so my sutures are not active anymore. I
Yeah,
understand.
yes,
Okay. I kind of figured that they were just always there.
no, there's lots of suture in babies, but when you grow up, they will be closing one by one, and then I think the latest closing one is around 80 years of age.
18,
80,
80,
80.
80.
Yeah.
You have. I still have an active suture.
Following that idea, the skull can deform its shape when you compress it. For example, in a concussion, do they move those sutures a bit?
Yes, so one of the role of the suture is to absorb shock. Yeah, but in young people, when the sutures are still open, it can absorb energy and dissipate. But in old people, it's closed, it cannot do that.
Okay, I'd like to follow up on Brent's question, because that was my second question this last year, because it strikes me that your whole thing is under pressure. Then you have like the hoop stress on this side. Then if you have a lot of interdigitation, it sounds like that's a way to get that distributed into shear. And so, my question is basically, where is shear in this story?
So at the beginning, I looked into all types of stress, but it didn't really, shear stress especially, didn't really make sense. So maximum, minimum principal stresses. Later, I looked into energy equivalent strain, and those were making good correlations. And again, one thing in this study, I need to make subject specific or animal specific model at several different time points, making getting very time consuming. So I implemented simplest possible elements. So, and also it was just linear elastic. And because of all those, it didn't really consider that inner structure or fiber orientation. So it wasn't making any big difference regardless of I'm looking at fear or any other stress. The only significant variables were maximum minimum principal stresses and energy difference.
Okay, well, I think that's an interesting open question. And also I kind of like shear in the sense that, I can't remember who, was it you or someone who said, it's all about maximizing the surface area. So area by itself doesn't matter, but if you want to make area matter, where's it used? In stress. And so, one thing that interdigitation can do is it helps you spread around the stress.
Yeah.
And then, when you have more of it, I imagine a lot of that, where you get more of that area is in shear direction. So, I'm just gonna put my vote, which is, sounds interesting.
Yeah. Yeah, again, I don't have any answers to that right now, but my love mate is continuing my work and looking into that.
I would be interested to know how the sutures are anchored into the bone. Same question, how, the emphasis sort of anchors itself into the bone. How cartilage fibers are anchored into, like, that would be a really interesting thing to try to understand how they're connected together. Then I think that shear stuff would really be interesting.
Yeah. So for this study, next step will be considering fiber orientation and considering more advanced model or material type. So that way, and also in this case, since it's quasi-static, I'm not really considering viscosity, but actually kind of suture is also viscous with different load rate behaves differently. So on this project, next steps will consider all that.
Forensics question.
Okay.
Can you look at a skull and determine a child's age by looking at the sutures?
Yes, people did that. And some people also looked at the sutures to define injury of the child. Was it abuse? Was it accident? Yeah.
Okay, my third and hopefully last question, is what this mechanics thing. So you had this result, which is the gradient of strain. So then, and I guess this hypothesis is basically empirical hypothesis, not mechanics. And so what does mechanics say about the results?
So strain gradient, I'm not exactly sure how it's affecting or causing or related to the bone growth in the suture, but in terms of bone, the strain gradient, there is a theory or belief that strain gradient can cause interstitial fluid flow, and osteocytes can detect that fluid flow and govern the bone adaptation. So on the suture, and or someone else need to look into that, but right now it's difficult to say.
Okay, well, I like that possible answer. Maybe I can suggest one myself, which is, first I thought it was weird to see a gradient, spatial gradient, because normally in mechanics, when I see that sort of thing, I see a Laplacian with a double gradient. But then, well, here's what I'm thinking. It's like, I think of everything as being like the heat equation.
Yeah.
Where you have change in time is proportional to basically a double gradient of velocity. And that's just saying that you want to smooth stuff out. And here it seems like, well, why do you have a gradient? But I think I understand is that strain by itself is already a delta of sorts. So in terms of, I don't know, some sort of a length, displacement like thing, I think think it is appropriate to say it is a kind of a lophobia. And then, then it's a nice story. I mean, I'm saying it, so it's probably wrong. But maybe your bone growth is concentrated where you have high lophobia. So then it would be just like the equation, which is basically an adaptation kind of equation.
Yeah, that might be one good way to implement one growth based on the strength growth type model, not finding mechanobiological relationship, stepping one step further that, and based on the strength, maybe we can simulate growth of the bone. Yeah, thank you.
There's a short question in there, what do you think, Tor?
So I know that people play football,
Yeah,
or they use their hands to hit the ball, and that's a heavy ball. So compared to normal people, their skull is on their eye level. Especially kids.
yeah,
You think that does
I don't know. So there's another study with white sheep and white-tailed deers, where they have, for example, white sheep that have bigger horn and they have fighting behavior, especially the male ones. In that case, male ones has much more complex suture than the females. On the other side, white-tailed deers, they have antlers, but it falls off and it stays on the 4 or 5 months per year. And male deers doesn't really show that fighting behavior. And in that population, there wasn't any significant difference between male and female deers. So yeah, maybe that receiving soccer ball on the head caused higher incapacitated suture. I don't know. Didn't really find any study like that. That might be a funny. Thank you.